available. We're just trying to make sure they're locked in and concrete, so we're not having this issue. Like, we thought it was concrete, we had it locked in, and then the people we were working with changed, and that's out of kind of our control. So we know that there's going to be more opportunities for flu clinics, but we also have to make sure that you're prepared. You can't go if there's an opportunity this weekend to do a flu clinic if you haven't learned how to give an immunization yet. So we're also working with the timing of when you learn that in pharmacology, so that you will have that kind of locked in, skills checked off, skills done, and be able to have that experience. So hopefully this week more dates will roll out, but we also have to look at where you are in your learning and so we want to try to catch those dates end of October and November when those come up for us. VTES, a quick update. I know some of you got your list today. I emailed her on Friday. I emailed her again, the VTES coordinator, this morning. So hopefully you'll get, she'll get back to you soon. I know somebody had emailed me saying, oh, she says, I'm not going to get my call list on till Friday. And I'm worried about my hours at VTES because I'm going to be 2 weeks behind. So Miss Solinger, Miss Cousineau, and kind of myself, I'll just throw myself in there for fun, are working on an opportunity to do some pediatric observation hours. That will be about 4 hours at a time on those days that you're in clinical or that you're on VTES. If you want to make up those times, you can. And so we are ebbing and flowing and trying to get you more opportunities. So when one thing kind of goes away or is not working out right, we're really trying to be proactive and giving you new experiences. So that will be coming out hopefully by next week-ish, so that you can go to that experience as a sub or for additional hours in general. It will be the people that haven't gotten their VTES experiences yet that get first choice to go to those days, obviously, because they're already behind. And so just know that we're going to offer it to them. And then can you guys send me can you guys email me if I know some people got their call list today. So if you still haven't got your call list, can you send me your names or email me just to make sure when I reach out again, I'm giving more up-to-date information? That would be great as well. Anything I forgot, Ms. Solinger? Any questions that are coming through the chat?
Yeah, Amanda just asked when should we contact you, and you said today, email.
Today, right now, today.
Right.
Let me know today. And then we'll also I'll create a list of the people that we need to put in the front for the pediatric observations. Okay, all right. I think that's it for me. And if there's no other questions from the students.
To Ms. Clark's email.
To my email. Yeah, the A Clark 1, make sure you say 1.
Don't forget
at
the
Hartnell, just remember the 1, at hartnell.edu. Yeah, and then I'll compile a list. Just email me your name and I'll create the document. Nozomi, I'll do that. Don't have to do any extra work. I'll create a VTES document for that.
And Kenya, no, you're not supposed to be doing VTES if you're doing the Clinica, because Clinica is Clinica. And then.
Yeah, so. And then I think the COVID clinic is from 3 to 7 tomorrow in Schular. And so I believe it starts at 4, but they want you to be there at 3 for setup and probably for tear down. And so you will need your scrubs and you will need your N95. Bring your own PPE just in case, so your gown and some gloves. Just in case they don't have that, I would rather you guys have that there than not have it. So put your skills kit in your car and take it out with you, or just grab your PPE and bring that out, just so you don't get stuck there and go, oh, I don't have it and I need it. So just be over prepared for that. Okay, all right. Well, Ms. Solinger is going to take it over. I'll see you guys tomorrow. Okay, bye.
Woohoo! Yay! All righty. Happy Monday. Woohoo! No? Yes? Anybody have a good weekend? Anybody? Anybody? A clark1@hartnell.edu. Or Ms. Clark, can you put it in the chat? Thank you. All righty. So what are we doing today? We're doing perfusion today. What I'd like to do, what do you see on your screen?
A diver.
A diver. That is not the right screen. Thank you. Let me try that again. Maybe that's, no, that one. There we go. Now what do you see?
Canvas.
Yay. Okay. So today, what I'd like to do is we're going to talk about perfusion. And then, so there's 2 PowerPoints that I would like to go over and some concept mappy things, because it sounds like people are having some confusion or needing some help getting started. And then also some information on antihypertensive medications, because some of the feedback that I've seen is that you guys are kind of struggling with that as well. So, you know, maybe there's some information I can give you. Hopefully you were able to assess predict somebody's risk, either yours or someone in the family, although apparently if you're under 40 and diabetic, it doesn't apply to you. Yay. But we're going to use that in one of our little group activities. If you have, I'm not doing housekeeping or parking lot right now, but if you have questions or things that you want to talk about, please put them in the chat. And then after we take a break, like around 11:40-ish, can somebody remind me at 11:40 that it's time for break? A timekeeper. And then I can look the questions over and then we can deal with those. Does that sound good? Yes, thank you. Okay, and then also so this is, I call her the purple nurse. It's registered, what is it? Registered nursing RN. She has great little videos. Yes, ATI is good, don't get me wrong, but sometimes I like the way that she explains things a little bit better. So if you need a refresher on circulation, we're going to talk a little bit about preload and afterload. Hypertension, we're going to talk a little bit about deep vein thrombosis and emboli. So these are just little videos. They're resources. There's a comparison between heparin and warfarin. So you have that available to you should you choose to watch those. There's also another little video on antihypertensive medications. And then I also put for you a risk factors article, and then the 2017 guidelines for hypertension are there. So you have that information available to you as well. Let's see. All right, so let's start with Giddens. Any questions on perfusion before we get into the PowerPoint? Nope, everybody, oh, now it takes forever for the PowerPoint to open. Sorry, there we go. And I did have the PowerPoints posted already. Yay. Slideshow from beginning. All right. Is that Maxine? You have Maxine's cartoon in front of you? Yes. Okay. I like Maxine. She's kind of funny. So we're going to talk about perfusion. And she's like, my doctor's concerned about my high blood pressure. I told him next time, don't leave me sitting in the waiting room for hours, right? That makes my blood pressure go up for sure. Definitely. All right, so we're going to describe the concept of perfusion. This particular PowerPoint is kind of based off of, is from Giddens. And then the next one is from Iggy. They kind of overlap a little bit, but that's okay because that's on the important points that you would need to know. And then we're also going to talk about some nursing interventions, collaborative interventions to optimize perfusion. So when we talk about perfusion, what comes to mind? What do you think of? So I say perfusion, oxygenation, they kind of go hand in hand. What else? Circulation, I can't hear you, Vanessa, sorry. Oh, cell and tissue death, potentially, yeah, if you don't have perfusion. You weren't coming through, Vanessa, sorry. Blood flow, yep. Vasoconstriction, blood moving to other parts of the body, right? So perfusion, along with the oxygenation, you know, it keeps us moving, right? It's circulating, blood circulating throughout our bodies. And so if we actually try to define that as Giddens does, you've got that it refers to the flow of blood, which you just said, through the arteries and capillaries, and it delivers nutrients and oxygen, right? So if you don't have those things, you're gonna have cell death, cell and tissue death. And so the range is, this is what you'll see in Giddens a lot, is you'll have one side that's optimal, like the best perfusion, everything's great, 100% O2 sat, great capillary refill, everything's great. And then you'll have some type of impaired perfusion, something kind of in the middle, and then you'll have no perfusion, which in this case apparently is blue or purple. And if you don't have perfusion, pretty much you don't have life. So you have optimal to no perfusion. Hello? No? Oh, Nozomi, can you mute, please? So this is just a, thank you. So this is just sort of a quick review. When we're thinking of perfusion, yes, it's the lungs, but then it's also going through the body to the capillary bed level to give nutrients to the body. And so there's that cute little one. And then there's different types of perfusion. So you can think of it as central perfusion. So that's the force of the blood that's moving by the cardiac output. We'll talk about cardiac output in a little more detail in a second, but that's the stroke volume times the heart rate, right? So that's the force, central perfusion in the center. You have to have, you know, adequate cardiac function. You have to have a heart that's working. There has to be some kind of blood pressure, and you have to have some blood volume, right? You need something to move through the body, and then you need that gas exchange, that air exchange in the lungs, and that would be considered central perfusion. You also have tissue or local perfusion. So that's the blood that's going to a specific part of the body. And for that, you need the enough pressure to move the blood and the nutrients through the body. And you have to have good capillary permeability, right? That means things can move through it if it's permeable, so that it can get the nutrients. And things have to be patent. You can't have clogged vessels or things don't go through. So I wanted to talk about preload and afterload a little bit, especially if you are in Groner's or Sutlef's group. Oftentimes they will ask you about preload and afterload. So just trying to help you out here a little bit. So when you're thinking of the heart, right? The heart's a muscle, it contracts, it fills with blood, it pushes the blood out, right? So that's basically what the heart is doing. It's a muscle and it's squeezing, it's stretching, and then it's squeezing is basically what it's doing. And it's pushing blood to the lungs for oxygenation, and then it's pushing blood systemically to the body, right? Basically. So the preload is the stretch, it's the filling, right? And so you have to have some stretch. What happens if you have too much stretch?
Congestive heart failure?
I'm not looking for a diagnosis, but potentially if you stretch too much, there's not necessarily you can have backflow. Yes, you can have backflow. Good. Yes. So congestive heart failure, you can have backflow, you can have too much filling, and it's harder for that muscle to move all of that extra blood through to the body, to the lungs, whichever direction, whichever one you're looking at. Or if it's too, if the muscle is not working right, or it's too, there's, you know, plaque or buildup in the muscle, then it's too rigid. It's really hard for it to stretch and or squeeze. So that's the preload. And then the afterload it's the squeeze. And in order to squeeze effectively, there can't be much resistance coming from the body or from the lungs, right? Because again, you'll get that congestive heart failure piece where if there's too much resistance, then it's going to backflow back. So it's the resistance that the left ventricle has to overcome to circulate the blood. So if we have hypertension, which is our exemplar today, it's going to be difficult to get the blood out. And so if you have an increased afterload, if there's increased pressure, that puts more work on the heart to do its job. Does that make sense? Does that help a little bit? Hopefully people have heard of preload and afterload, but probably it was in anatomy and physiology ages ago. But that's kind of what you're looking at when you're thinking of perfusion and moving the blood to get the nutrients to the body. And then this is just a little diagram that kind of shows you when you're looking at, when you get to your arterial pressure, your blood pressure, you're looking at that preload, afterload, and the contractility of the heart, right? And so then that's going to get you to your stroke volume and your heart rate, which is cardiac output, but then you're fighting resistance. So that's kind of how it goes in sort of like a flow chart if you needed to look at it that way. So what happens when there's, when things don't go right? So it's not always, I mean, hopefully it's always fine, but if you're looking at problems with central perfusion, so that's when the cardiac output, which is your heart rate, how fast the heart is pumping, and the stroke volume, which is how much per beat it's perfusing. If that's inadequate, then that's a problem. So if you are, what's bradycardic? Bradycardic is
Slow.
slow, right? Bradycardic would be slow heart rate. Tachycardia would be
Fast heart rate.
too fast of a heart rate, right? So if you have a very slow heart rate, if you're bradycardic, then how might that affect perfusion? Which is not to say there are some athletes that run in the 60s. I get that. But they have very adequate perfusion and musculature. So if the heart rate is slow,
It's going to be less cardiac output, so therefore less perfusion.
right? So not enough oxygenation or perfusion. And also if it's too slow, yeah, it's not necessarily being able to perfuse to get the output. What if the heart rate is really, really fast? Like what if you're in what they call supraventricular tachycardia, where your heart rate's over like 212? How much of that stretch and squeeze?
You may overwork.
Yes, you can overwork the heart. The heart's going to get tired out. It doesn't fill enough because it's going so fast that it can't fill and adequately push the nutrients out to the body. Good. And so when that happens, you get less oxygenation, and then you can get shock and, ischemia, seizure, coma, death, that kind of thing. That's a thing we say, seizure, coma, death. And so then when you're looking at, so that's central. And then if you're looking at local tissue perfusion, so you get loss of the, for some reason, there's, the capillaries aren't permeable, and so the nutrients don't get there, or you're not getting to the finger. Think of, what do I say, in diabetes, what happens to a diabetic's foot or fingers? I've seen fingers as well.
Little to no blood flow, poor circulation.
Right, poor circulation. And so, and you get the numbing neuropathy, right? And so what happens with that poor circulation? What eventually happens to the tips of the fingers or to the toes? Necrosis. Yeah, necrosis, right? Arteriosclerosis is more of in the vessels. So I'm talking specifically like at a localized tissue area. So we're talking toes and fingers, could be other parts, but I don't know how many of you have actually seen necrotic extremities. But oftentimes amputations occur because of the necrosis and cell death as a result of the poor perfusion to that particular localized tissue area. Could I define shock for you? I could, but we're not going there because there are many different types of shock. And shock is like would be systemic, right? So ischemia could lead to shock. There's many things that can lead to shock. Ischemia is cell death, or actually not cell death. Yeah, cell death, like decreased blood flow. Shock has like a whole physiological definition beyond the scope of first semester right now. Okay, are you with me so far? We've got central perfusion, we've got local perfusion, we know what perfusion is, the concept, okay. And so what are risk factors? So risk factors or populations at greatest risk would be older adults. Again, this is from your book, and then also low income, low educational level individuals. Why would that be?
They don't have access to healthcare.
They don't have access. Unable to go to the doctor.
Yeah.
Yep.
They may not have information like education about symptoms to watch out for.
Right. They also may not have, so for example, when we're talking about hypertension and you have to have an appropriate diet, maybe they don't have the appropriate resources in their community to have a heart healthy diet, potentially. And so what I want to do now is put you into some breakout groups, because you guys like that, and talk about, hopefully you did that self-assessment of the risk factors. If you didn't, you can talk about it, you can pull it up, and talk about what the individual risk factors are associated for perfusion. So like what would an example be of a risk factor?
Poor diet.
Smoking.
Mm-hmm. Smoking, obesity,
Poor
Right.
diet.
poor diet. Not
High cholesterol.
but yeah. So that's what I want you guys to do when I put you in your breakout groups. Hold on, let me find you. So yes, but I want you to go by what the book says, because there's like 4 or 5 specific risk factors for coronary artery disease. Where did we go? Okay, breakout room. So I'll give you maybe 5 minutes. How big or small do you want the groups? Like 6, 10? You're not going to get your clinical groups. Sorry. Let's see. 5, 6, 7, 8. 5 or 6 works well. That's kind of what I was thinking. Whoops, I went the wrong direction. Okay, and so we're going to do like 5 or 6 minutes. There we go. And you guys know what you're doing, right? You're going to talk about identify risk factors according to the resources or the book. You're going to then share the results of your risk factors, and then think of, based on those risk factors, like for 2 that we said, obesity and smoking, what teaching would be indicated, right, to decrease the risk. Does that make sense? Yes, maybe?
Yes.
Yes, thank you. Okay, so we'll do like 5 or so, 5 to 7 minutes. All right, have fun. There we go.
Mrs. Solinger, so with perfusion, does those pressure socks, do those help with patients that are like paralyzed and not even open?
Because it keeps the vessels from like expanding too much. So it keeps the blood from pooling like in the extremities.
Got it.
Okay. So what do you see on your screen? Am I still sharing?
No, it's just you.
It's just me. Oh, all right. Then I shall share. So what risk factors did you come up with?
Smoking.
Smoking.
Obesity.
Obesity. And are those modifiable or non-modifiable?
Those are
Modifiable.
Modifiable.
Our
Immobility.
group,
Yeah.
our group talked about diabetes and how some people, when they have diabetes, they want to put it with the however you say that.
Unmodifiable.
Yeah, but actually it's like, yeah, they might have not chose to get it, but they can choose to do live a healthy lifestyle to try to have it under control. So.
Non-modified. Yeah. Genetics. Sedentary lifestyle is modifiable. Age is unmodifiable. There you go. So you need to know what the risk factors are, and you need to know which ones are modifiable or not modifiable. And that's also going to help you when planning your plan of care and teaching patient education, right? Depending on what your patient is dealing with. Where are we on time? Oh, I have 2 minutes. Okay. So how do you know that a person has compromised perfusion? So we're not going to do this in your breakout groups. We can do it. We can do it here. How do you know if someone they have purple skin? You guys know how to annotate on there? Cyanosis, edema. You guys can write stuff on the screen if you want. What's edema?
Swelling.
Retention of fluid.
Swelling.
Retention.
Yeah, fluid retention, right? What's cyanosis?
Inadequate perfusion.
But how does it present when I look at somebody that has inadequate perfusion?
Shortness of breath.
So let's stick with cyanosis for a second. What is a person who's cyanotic? What do they look like?
Like blue, purplish color.
Yeah, like bluish skin. Yeah, exactly. Good. Because they're not getting perfusion, right? What's syncope or syncope? What's that?
Loss of consciousness.
Yeah, like fainting. Yep, passing out. What's capillary refill? How do we check cap refill?
Less than 2 seconds with a press on the tip of the finger, and it goes right away. So
nice. Okay, let me get through this one and the next slide, and then I'll give you guys a little break. And so when you get to do your focused cardiac assessment, these are things that you're going to be looking at. Somebody said shortness of breath. Yes, that potentially can be a combination of perfusion and oxygenation. Definitely. Let's see. Let me go to the, whoops, nope, hold on. Gads, technology. There we go. Oh, go back. So when you're looking at ranges, this is for adults. I'm gonna take that. Oops, that didn't work. Hold on. These are the ranges. There's new ones that have come out, but this is basically right now what I would take test questions from. If I would do that, it would be from this slide. I would just know that are some more modified. It actually what is it, 135. In some instances, it's a little higher and a little lower. The main thing that they changed was that they took out pre-hypertension. There was like a pre-hypertension stage and they got rid of that. So you generally know that the 120/80 is normal. And if it's a little bit elevated in the 120 to 130-ish in there, that's elevated. And then you have stage 1, stage 2, and hypertensive crisis. And so just to know which ones, you know, like know the difference between stage 1 and stage 2. Hypertensive crisis is sort of, again, beyond scope of first semester because when we're talking about health promotion. But if somebody comes to you, with 180 over, you know, over 120, or I mean, like, you know, that's bad. That's bad. You're going to be giving them like hydralazine or some kind of, you know, immediate medication. So just make sure that you know those. So let's go ahead and do like a 5-minute bio break. Come back at like 11:46, and then we'll finish this one up and move on to the next one.
Miss Sonia, a quick question.
Yes.
When the study of hypertension, I stumbled onto a type of hypertension is called white coat hypertension.
Yes. And so I'm sorry, what's the question?
So how would you recognize white coat hypertension over than the other ones?
So what are some suggestions people have? Like, how would you differentiate white coat from actual hypertension?
I mean, isn't it white coat when it happens in the office and out of the office, right? So if a patient comes in.
Right, and so what happens is if you come in, generally speaking, if you come in and you get like an elevated or a stage 1 type of reading, you wait a little bit, you know, you wait like 10 minutes, maybe 15 minutes, take it again and see what you get. And then oftentimes they'll have them come back in a week or two, or have them do home monitoring and then go from there. A lot of times, like Amanda's saying, that you can ask the patient, they'll know that, but not always, but hopefully you're not diagnosing hypertension from one blood pressure reading. And plus, if it's the first time you're actually doing the blood pressure, or if they can't really tell you, you should probably do a 2-step just to know where the range is. But I've never seen anybody do that. So we'll talk about that a little bit in Iggy. Iggy addresses that more than Giddens does. And it has to be 2 consecutive, yeah, both arms. Is it 2 or 3? I can't remember. Sometimes it depends on the physician what they want to do. But at least 2 consecutive readings, and yes, checking both arms. All right, go take a break.
Miss Sandra, I want to say the book said two readings.
Okay. I think it's 2, yeah. I've just seen it dealt with different ways.
Exactly.
Depending on a physician.
Provider preference.
Yeah. Okay. Yep. Get through that. So I think I got the reading right this time once I updated it. All right, I'm gonna keep going because it is in fact being recorded. So when you're taking your history of the patient, generally they're coming in because there's a problem. So what problem are they having? Their pain, there's the fainting, are they dizzy, do they have trouble breathing, or that they have edema, the bleeding and bruising, fatigue. So those are things that could indicate that there is a problem with perfusion. And then if you're looking at infants and children, generally it's poor feeding, poor weight gain, oftentimes developmental delay. The squatting has to do with specific cardiac anomalies that happen in children, and so they squat to increase the perfusion in the upper body. But generally that's what you're going to, when you hear the patient complain of those symptoms, then you should be thinking perfusion. And so when you're looking at altered perfusion, we talked a little bit about that. The vital signs, the respiratory rate, the heart rate, the pulses might be thready or bounding. You might hear murmurs on auscultation, things like that. And you want to check the color and look for edema. On palpation, also you might be looking for like pitting edema. When you push, when you press, does the skin stay indented? So common diagnostic tests, I don't really, excuse me, expect you to know like everything there is to know about all the diagnostic tests. However, there are certain lab tests, and I'm going to go over the cardiac enzymes in a second. Complete blood count, you can, that can tell you your white blood cells, your red blood cells. It can give you some ideas of iron binding capacity. Excuse me. There's also coagulation studies, which we'll talk about a little bit in the other PowerPoint. An ECG, right, where you put the leads on and get the heart wave going there. Also exercise or pharmacological tests. They actually can inject medication to make it like you're exercising, and then check how your heart reacts to that. And then you can always do ultrasounds, x-rays, or dye studies where they'll inject dye and look at where it goes. I don't know. I've always said EKG, but it's electrocardiogram, so that's where the C comes from. So probably ECG, but I think everybody just kind of says EKG. Okay, don't panic. Cardiac markers, don't need to really know this slide. Just know that, I mean, you do and you don't. So the thing to know is that CRP, which is the one at the bottom, that is an indicator of inflammation, which can also mean that there's an infection or that something's, there's some damage to the heart. We use CRP with kids and neonates, mostly neonates, because it will show us it's an inflammation marker. The other one to think about is the troponin test, because they do those. It gives you a better picture of whether there's been cell death or damage to the cardiac muscle. So those are things, these are enzyme tests, blood tests that you can do that will show you that there's been some kind of damage to the heart. Oh, it's a K in German. See, I learn all kinds of things. There we go. Okay, and then interventions. So we talked about these, right? You said you're ahead of the game. Look at this, stop smoking, proper diet, exercise, weight control. So primary prevention, remember those are things to keep you from having a perfusion problem, right? That's what primary prevention is. Secondary prevention is a screening of some type, right? And so that's why the blood pressure screening goes under secondary prevention. And then treatment strategies. So depending on what the cause is, diet, increasing activity, the pharmacotherapy, the drugs, we'll look at that. That's in Iggy and McQuistion. And then this is just to know different things. So if the injury or the problem with perfusion is local, right? Like an endarterectomy is where they go into the carotid and kind of roto-rooter scoop out any plaque. So that's in that particular artery, or putting a stent in to keep it open. Sometimes you can do bypassed or grafting. You take a graft from some other place to add into the particular local area, or you can do, if it's central perfusion, you're dealing a lot with the actual heart. So valve surgeries, transplants, pacemakers, that kind of thing. This is mostly an FYI type slide. So when we talk about interrelated concepts, wow, look at that. Like everything's related to perfusion pretty much. So that just goes back to the symptoms that come if you have stress. Perfusion can affect your memory, elimination, your gas exchange, nutrition, like and they're all back and forth. Not all, most of them are back and forth. Like stress and coping goes back and forth. You see the arrows have like one-way or two-way directions. So as we proceed through, like we've done nutrition and now we're on perfusion. I think we're doing gas exchange next. So we'll see how they start to interrelate to each other. We've already seen, right, how nutrition can affect, right, with the obesity and having a heart healthy DASH diet, Mediterranean diet, those kind of things can help with perfusion. So I want to get to Iggy, so I don't want to do breakout groups for this because I have some practice questions in the other PowerPoint. But what are some medical conditions that you can think of across the lifespan? So now we're looking at medical. We're not thinking conceptual, we're thinking perception, which is the concept, but what medical conditions are perfusion problems?
Hypertension.
Hypertension.
Heart failure.
Hmm?
Heart failure.
Heart failure. Preeclampsia, yep.
AFib.
AFib.
Hyperlipidemia.
TIA, stroke, yeah. Transient ischemic attacks, hyperlipidemia. There's congenital heart defects, like tetralogy of Fallot and transposition of the great vessels, things like that. Nice. Pregnant women, good for that. Nursing school, yeah. Not Mrs. Solinger's class, just nursing school. No, I'm kidding. Mrs. Solinger's class too. You guys are doing good. Okay, so that's a wrap. So here's the things you need to know, right? You need to know the difference between central and local perfusion, primary versus secondary hypertension, which we'll talk about in Iggy as well. Interventions to prevent hypertension. We'll talk about venous thrombosis in the other PowerPoint. How do you know there's poor perfusion? The blood pressure ranges for adults. The risk factors, right? And if they're modifiable or non-modifiable. And then basic, like the concept of perfusion and like preload, afterload, right? So you're not going to get a question that says, is this central or local perfusion? It's going to be like a little scenario question, kind of like what Mr. Beamer was saying with pharm, as the whole class goes, you know, it may not be the actual medical diagnosis, but it'll be a concept that has to do with that. Yeah, sickle cell is perfusion. Asthma is more of a gas exchange than a perfusion. Sickle cell is a perfusion because of the way it affects the red blood cells. Okay, so that should give you, right, and this goes directly back to the objectives. So when students are asking like, what should I study? Like that's, those are things that you should be looking at as the objectives for each lesson. Okay, let's do Iggy, because there's some practice questions for you, because you were asking for some practice questions. I know, I should have had it open already, sorry. There we go. Okay, there we go. Okay, so now we're going to look at more, it's conceptual, but now we're going to look at the more nursing type of things. Okay, so, oops. Is that overlapping? No. Help, Hugo. How do I?
What's going on? What is?
So I'm trying to do poll everywhere, and I don't know why it's giving me more than one. I'm trying to pull it over, and it won't let me pull it over.
I'm not sure about that.
Okay. Well, I don't think it's done that before. I don't know. All right, so I'll read it to you and you guys can, I don't know what's going on with that. That is really weird. Oof. So you're caring for 4 clients with a history of hypertension, and which client would require intervention? So let's go with the one we can read. I did start the presentation to see live content. So you have a 30-year-old with preeclampsia and their blood pressure is 120/68. Do I care that they have preeclampsia? Because we don't even know what preeclampsia is necessarily, right? Hello? People, right? Do I care that they have preeclampsia?
No.
What am I looking, not really. What am I looking at?
Blood pressure.
And what is that blood pressure okay?
Yes.
Yes.
Yes. Okay, now I have a 28-year-old with an LDL of 140, blah, blah, blah. The blood pressure is 114/84. Does that require an intervention?
No.
No.
Because
Blood pressure is normal.
Blood
blood
pressure.
pressure, yep. Okay, and then I have somebody, I forget how old they are, they're on diuretics and their blood pressure is 160/80.
Concern.
So that might be a concern, right? Why? Because they're on diuretics, so they should have a little more normalized blood pressure, systolic, right? And then what about, I think this is chronic heart disease, I can't remember. Oh, kidney disease, there we go, it tells me right there, kidney disease, with 138/80. So of your 4 choices, which one would you think would require intervention?
B, diuretics with a blood pressure 160/80.
There you go. Does that make sense, reading through the question that way, like what to look for in the question? Yeah, okay.
Yes.
Sorry, I'm sorry it didn't, I don't know why it's doing this, I'm so sorry. I've never had to do that before. Normally you can join in and you put your answers up. So we're talking, the patient with hypertension is discussing the cause of hypertension. Which statement by the nurse is appropriate? So you're gonna have to kind of know essential hypertension versus secondary hypertension, pregnancy. So you have to think now, okay, essential versus secondary. So what is essential hypertension? Do we know the cause or do we not know the cause with essential hypertension? The cause is unknown, right? With essential hypertension, we can't really pinpoint a cause. We look for it and finding no cause, we go back and say it's essential hypertension. What is secondary hypertension? There's generally some kind of cause, but it's like, you know, high, the adrenals aren't working right, Cushing's syndrome, things like that. So you kind of have to know that difference. And so then we look through our choices. Pregnancy can cause essential hypertension. True or false?
False.
False. You get hypertension, but it wouldn't be essential. It would be secondary. It would be due to the preeclampsia, something going on. Cholesterol can be a big factor in the development of essential hypertension. True or false?
False.
False.
Okay, then stopping intake of caffeine can cause hypertension to go away. Oh, how do I do that, Hugo?
You would just have to reshare. I think you have to stop the
Oh,
reshare.
okay.
And when you share your entire screen, it looks like it might fix the issue.
Oh, is that what it is? Oh, thank you. Sorry. Did I do that? No, that didn't work. Yeah, pick a screen. So stopping intake of caffeine can cause hypertension to go away. True or false?
False.
False. I have a false.
It could be true.
It could be true. I have a true, I have a false. That's 50-50. I can't figure out how to do it, Hugo, sorry. So stopping caffeine. So if I quit drinking coffee, my high blood pressure is gonna go away.
False.
False, right? And then race is associated with secondary hypertension.
True.
True.
False.
True.
False. Secondary hypertension. So race is not necessarily associated with secondary hypertension. Secondary hypertension has a specific, like you have Cushing syndrome or it's aldosterone. There's a specific medical cause. So that would be false. So we said that A, C, and D are false. I know somebody also said B was false. So what do you think the answer is? B.
B.
Right? B. Right? Cholesterol can be a big factor. Hopefully that's helped. This is helping a little bit, like how to read the question. Sorry. Okay, what's the most common symptom when a client is diagnosed with hypertension? Headache, slurred speech, fainting and dizziness. Hypertension is often asymptomatic.
D.
D.
I got D. I got headaches. D. So when I first looked at the question, I thought headaches as well. That was my first thought. And I didn't read the rest of the selections. So you have to make sure that you read through the whole thing because hypertension is often asymptomatic. So D is the correct answer. But of those other three, headache would be the best choice, except that often it's the silent killer. Exactly. Took the words right out of my mouth. There we go. Okay, so these are the same objectives from the other one. Does that help going over the questions a little bit? Like how to, right? Like how to think through
Yes.
a little bit? Okay.
Ms. Solinger, can I ask you a question about that last one?
No. Yes, you can. Of course you can.
So like what kind of confused me about this is I understand hypertension is often asymptomatic, but then the question says, what is the most common symptom? So to me, I read it as like, I understand it's asymptomatic, but if there is a symptom, what's the most common one?
But there's really not necessarily a common one, I guess, is what the question is getting at. And yes, it's asking for a common symptom, but when you have hypertension's often asymptomatic, like that's what it, I don't want to say that's what it is because I understand how that question is being asked. But if it was like another, like tingling and numbness or something, say that was your fourth choice, then I would go with headache. Okay. But because it has that it's asymptomatic, you know, and maybe I would word the question a little bit differently. Okay. If it were my question. It's not my question. It's Iggy's question. So I'll talk to her. I've actually met her. I've been to a couple of her conferences. She's pretty nice. Very smart. Okay, same objectives, right? And so now we're looking, they now have desired blood pressures. You're still gonna go by that other slide that I showed you. That's the slide you're gonna go for test questions if there's a test question. Got it? Yeah, what is the most correct answer? Exactly, it is not a trick question. So they've sort of defined it now for people younger or older. They give you a little more leeway as you get a little bit older. Again, here's your essential or primary hypertension. So I asked you the questions first to kind of see where you were with the information, right? And then now we're going to go through the information a little bit. So the risk factors, obesity, smoking, stress, family history, right? So this is essential. Those are the risk factors. Diagnosed if there's no clear cause. They look for all these other things, and then if they can't find it, they say, no, it's essential or primary. Secondary causes would be like renal disease, aldosterone, too much aldosterone, pheochromocytoma, which is an adrenal tumor, adrenal, like kidney, adrenals, which are on top of the kidneys, a tumor there. You see that mostly in kids. Cushing's, which is increased cortisol. So nursing school has the potential to give you all secondary hypertension because you're constantly in stress, right? And so your cortisol is up. And then there's also medications that could potentially, side effects could be hypertension. So that's why you have to kind of look at the medications as well. So now we're looking at the assessment. So this is looking at the Tanner's, like noticing. Remember we kind of talked about that a couple weeks ago. You're looking at the patient history. You're looking at your patient. You're kind of asking them questions, psychological, mental health type assessment, and then any diagnostic testing that is available. And then analysis, how do you interpret it? Is there teaching that needs to happen? Is there potential for decreased adherence to the therapy? So we talked a little bit for the students that are in Clinica, like what actually is non-compliance? You know, what is non-compliance versus, because to me, non-compliance is I'm not doing it because I don't want to, because I want to do this or I want to do that. But just because I didn't take my medication doesn't mean I'm non-compliant. I couldn't afford it. I couldn't get to the pharmacy, something, I don't know, I didn't have transportation. I ran out and couldn't get another appointment because I had to go to work or something, right? So you kind of have to keep that in mind when you're talking with your client and doing the analysis and assessment. And so then you're going to respond. They've told you something and you're going to plan and implement. You're going to respond. So maybe there's some health teaching, some lifestyle changes that can happen, because a lot of times people really don't understand. Oh, it just runs in my family. Everybody in my family has it. Everybody in my neighborhood has it, right? And so maybe you can, you know, do some education there. So different things that you can do would be sodium restriction, and I have some other slides that will help with that in another thing. Weight reduction, decrease your alcohol intake, exercise, decrease stress, which like for the next 2 years, forget that unless it's summer. Avoid smoking. I like the complementary and alternative therapies. I like, you know, aromatherapy, stuff like that. Some people like meditation, things to kind of reduce your stress. My complementary and alternative therapy is eating, is food. So that makes weight reduction kind of cancels each other out. Meditation is good, those types of things. So try and find, when you do the assessment, like find out, do they know about, like I'm gonna call it CAM, or CAT, I should call it CAT, complementary alternative therapy. Like find out, do they have something that they do, that they, you know, that they like to do? Do they exercise? Is there something, if they like swimming, is there someplace they can go to swim? You know, it's difficult to say, well, here, do the DASH diet and give them a handout. Excuse me, or you guys can look up DASH, Mediterranean. I'm not even sure they specify a specific diet now, because I've seen Mediterranean, like a lot of different ones, as long as they have low sodium. Those types, but you want to assess first and then see what you can work with them, and do small measurable goals first. You know, if they're drinking a 6-pack every night, probably going to be difficult not to, you know, drink a 6-pack every night. So let's, you know, reduce the intake over time so that the next time they come back, it's like a 6-pack a week kind of thing. Small, measurable, attainable goals. Okay, don't panic. Yes, these are medications. It's okay. This is just a list of potential medications. I have another sheet for you that explains them in more detail. Hopefully you remember something from pharmacology. I don't know if you do or not. So beta blockers are one type of medication. They end in the LOL. That's how you know they're a beta blocker. And they work on beta 1 and beta 2 receptors. Renin inhibitors, so it's aliskiren, some, you know, Lasix people know, right? Lasix, probably hydrochlorothiazide, calcium channel blockers, PRILs, ACE inhibitors always have PRIL. And then these are ARBs. The ARBs usually have the artin on the back of them. And then spironolactone kind of fits in two different ones. And then when you're looking at care coordination, transition, right, home care, right, because hopefully the patient's going to go home at some point. Can they manage themselves at home? Will they need home care follow-up, right? This is where that coordination of care and collaboration comes. You know, maybe there's a discharge planner that can help. Do they know how to get to the pharmacy? If you want them to do blood pressure monitoring, do they know how to work it? Do they know what kind of batteries it needs? Do they know, like, where are they going to put it so the dog doesn't chew it up? I mean, literally, things like that, so that they can remember to do it. Are there any classes they can take? Any support groups? Support groups are really good. People within the same situation, right? They can give each other help. There's probably, you know, not blogs anymore, but like there's different groups even online, or Facebook chats or meetups, or I don't know, you know, whatever works. And then ask them to explain it all back to you, right? So ask them how they're going to develop this in their own, you know, in their own home. You know, can they do the shopping? Do they have some place to put the monitor? Do they understand when to take their medications? You know, some you have to take at night. Like, am I going to take my diuretic at night? Anybody? Huh?
No.
No, or I'll be up all night going, no, thank you. I'll be up all night. But I do want to take my cholesterol lowering medication at night, because that's the best time to take that particular medication. So do they know that? Do they need to write a schedule out, right? All that kind of stuff. That make sense? Like planning care? Yes? Okay. Okay, so now we're going to move on to thromboembolism, venous thromboembolism. We'll come back to hypertension when we're done with this, because I want to review the meds a little bit and work on a care plan with you, so you guys know how to kind of do a concept map. I want to work. Yes, simvastatin, very good. Your statins. Good job, Francisco. Thank you. So thrombus is a blood clot. Why do we not want blood clots?
It can block vessels.
Block vessels. What else?
They can travel to the lungs.
They can travel to the lungs, yes, to the heart or the lungs, right? Stroke because it impedes perfusion, right? The blood clot is impeding perfusion. It's blocking it somehow. So phlebitis is an inflammation. So you've got a blood clot with inflammation in a vein, which is not good. And so they talk about Virchow's triad, which are factors that contribute to the thrombosis. So there's injury to the vessel, some kind of vessel injury to where it's, for some reason it's, you know, stretching out too far, or something's happened. It's narrowed, right? A lot of times it's narrowed. You have a reduced blood flow for some reason, could be diabetes, some different things. And then there's hypercoagulability. So in other words, the blood's going to clot. It's going to coagulate for some reason more than not. So those are the things that can lead to a venous thromboembolus. So what are some situations where you might have one or more of those factors in play?
Bed rest.
Bed rest. Yeah, okay, so long airplane ride, right? Good. Trauma, bed rest. So bed rest, and what else?
After surgery?
Yes, post-op, after surgery. Yes. So you're laying there or you're sitting there, and if you're sitting there, all the blood's pooling in your lower extremities. It's really difficult for it to get back up to the heart. After surgery, you're generally flat on bed rest, difficult to get up. So that's when they'll use the TEDs, the thromboembolic, the stockings, and or the sequential compression devices. Yeah, compression stockings, thank you. Or the sequential compression devices. And then what happens is, yes, then the clot becomes dislodged and then it travels. So we don't want that to happen. Whoops. Sorry, technical difficulties here. There we go. Okay, this is a little video on Homan sign. We used to teach Homan sign, especially in OB postpartum, where you actually lift the leg up a little bit with the hand under the calf there, and then you dorsiflect the foot. And if there's like sharp pain, then potentially they have a DVT. But why are we not using that? Why are we not really doing that anymore?
Can you probably dislodge it yourself? Cause a problem?
Yeah, that's what we found out, is that actually we could potentially be moving the clot, which was not a good thing and not what we wanted to do. So we don't really check Homan sign anymore. But calf or groin tenderness or pain, swelling, unilateral swelling. So one side, localized edema, you could see it on the ultrasound or MRI. And then just so you know, if you hear the term D-dimer, that's special lab that they can order. It's after a blood clot has been disintegrated, there's a degradation product, and so that tells you that there probably was a clot or still potentially could be clots there. Check the left leg. There we go. Okay, so again, potential for injury as we're interpreting, we're analyzing now, we've done our assessment, they've told us this is what's going on, or they're post-surgical. And so we want to prevent injury, hopefully non-surgical management. That's also one of the reasons we want people to ambulate though, is to get the circulation going. It used to be that we keep patients on bed rest for like 24 hours, like C-section patients for like 24 hours. And then we realized that that was not the best management. And same thing for surgical patients. Now they ambulate. Yes, exactly, Vanessa. We get them up, hopefully up as soon as we can, as soon as possible, given what their situation is, to ambulate them to get that perfusion going. They probably don't want to do it, but that's what we're going to do with them. So non-surgical management would have to do generally with anticoagulants. So anticoagulants like heparin, enoxaparin, and Coumadin, those are really the ones that you're going to see in the hospital. Have people seen anybody getting enoxaparin? I mean, you've only been there one day, I get that, but enoxaparin, the injections, generally they'll give them, it's a sub-Q injection in the abdomen, as an anticoagulant for people that are like on bed rest for a long time. Heparin usually is more, like we'll put them on heparin drips and things like that. Sometimes we'll use it like enoxaparin. And then Coumadin is like, you can take that at home. That's something you can do at home. I gave you the antidotes just in case any of your clinical instructors ask you, so at least you have the information. All I basically want you to know is that we do use heparin and Coumadin. And then also to know that there's a difference between an anticoagulant and a thrombolytic. Can somebody explain the difference between like TPA and heparin?
Anticoagulant is going to stop it from producing in the first place, whereas a thrombolytic is going to help it to break down once it's already produced.
Couldn't have said it better myself, yes. And sometimes you do have heparin for dialysis patients, right? Because they're on dialysis. We can't have a clot, right? There's no way, because that's their life is dialysis. And how long are people at risk of a clot after surgery or a long flight? I don't know the answer to that. Type it. So the anticoagulant keeps you from getting a clot, hopefully. A thrombolytic lyses the thrombus. So if somebody comes in with a stroke and we want to find out which kind of stroke it is and whether or not to give TPA, right? You have to decide, because it's a clot buster. They call it clot busters, right? Thrombolytics. And then there are, what are now, because there's a newer classification. I feel like I'm seeing these ads all the time, like Xarelto, Eliquis, like it's always, there's all these ads. And so Pradaxa, they're called novel oral anticoagulants. Andexa is an antidote to, I think, Eliquis. or Xarelto. I think Xarelto and Eliquis Indexa is one, and there's others that they are developing. But just so that you know that those are out there. And then again, just so you're familiar, I just want to introduce you to the terms. There's labs. So we talked about the D-dimer, right? Which is protein from a clot that's dissolved. And then you also have something called PTT or PT, which is partial thromboplastin time. So what you're looking at is how fast is your blood clot? There's different pathways. You don't need to know that. You just need to know that there's a way to find out the overall speed at which the blood clots. And if it's Coumadin, you check, it's warfarin Coumadin, you're gonna check a PT. And if it's heparin, you're gonna check a PTT. Just again, in case your clinical instructors ask you. I'm not gonna put a question on that. You will get into this in later semesters in detail, but this is just a way to remember that. Because we have to know how fast the blood is clotting, right? If it's clotting normally, then we're good. But if it's, yeah, there you go, lysis. Once you, if you're taking the heparin or the Coumadin, we have to make sure that it's at a therapeutic level, right? And so oftentimes you'll do heparin in the hospital till you get to a therapeutic level, and then when they go home, they'll be on Coumadin because you're not going to do heparin at home. So you have to kind of wait till you get that therapeutic level. So then that's how you test that it's the anticoags are at a therapeutic level, is by doing these blood tests. And then this is just sort of an overall slide that tells you, the ability to clot, that kind of thing. So again, more informational than that you would have to know for an exam. Okay, so let's see, how did we do this? Okay, so little mini case study. So you have a 58-year-old African-American man visiting his healthcare provider for an annual checkup. And the family history includes hypertension and type 2 diabetes. So he's pretty much in trouble from the get-go. He's a cigarette smoker and he's 30 pounds overweight. And he works as a car salesman in a very competitive market. So basically he's screwed, right? And so, see here, we're gonna get, hold on, let me go back. I don't know why it's doing. So what risk factors does he have? Huh?
History of hypertension and type 2 diabetes.
Mm-hmm.
A smoker,
Mm-hmm.
overweight, and stress related to his work.
Yeah, he has like all of the D, all of the above, right, Francisco? Cigarettes, ooh, nice annotation. I bet that was Hugo. Cigarette smoker, right? And 30 pounds overweight. And car salesman. I mean, yeah, not good. So we found his risk factors for hypertension, good. And then we're going to check the vital signs. So his blood pressure is 142/90. I can't tell what the heart rate was. Respirations are 8. His temp is 97. Sorry, I can't remember what the heart rate was, but it's within normal limits. So does he have hypertension or not?
Yes.
Yeah, respiration's 8. I know, right? I was like, whoa. So, so based on what we're given, it doesn't say, is this the first time, the second time, it's his first time with the doctor wearing a white coat, right? It doesn't put any of those things on it. It's purely what the question wants to know is, do you know what blood pressure is hypertension? So is 142/90 hypertension?
Yes.
Yes. So the answer to the question is yes, he has hypertension. Does that make sense? Yes, 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 yes. Stage 1, nice. Okay. So what can he do to improve his health? And what points are you going to include in your teaching plan? I believe that's quit smoking or decrease smoking and caffeine, lifestyle changes to control blood pressure, checking blood pressure only at the clinic to ensure accuracy. What do you think about that one?
No.
No. What would you like them to do?
Check it more frequently
Where?
at home.
At home.
Really? Yes. Yeah, should hopefully be, and make a log. Nice, Christine. Yeah, right. And keep track, like blood sugars, right? You're going to keep track of the, yes. And so they can take it to the doctor. Beautiful, right? Exercising and weight loss to decrease the need for blood pressure medications, potentially. Yeah. And then alternative therapies. Yeah. So pretty much everything except C. Does that make sense? And it did say that it was a select all that apply. We'll do better next time. Okay, so hydrochlorothiazide, hydrodiuryl. May or may not know it, that's okay. But the doctors ordered 25 milligrams by mouth every morning to help with the patient's hypertension. When you're teaching the patient about the drug, which statement are you going to include? So hopefully you know that it's a diuretic. The name is hydrochlorothiazide. So what type of diuretic is it? Loop, thiazide diuretic, or a potassium sparing?
Thiazide.
It's a thiazide. It tells us it's a thiazide, right? And so since we know that, this is a loop diuretic that decreases sodium reabsorption. True or false? False, no, right? Whitney's shaking her head no. Eat foods rich in potassium, such as bananas and orange juice. That's a potential. A potassium supplement will be prescribed along with this drug. That's also potentially a potential, right? Hydrodiuryl is a potassium sparing diuretic that helps prevent the loss of essential potassium. We already said it was a thiazide diuretic, right? So that takes loop and potassium sparing out of the equation, right? So we're down to B and C. So we know it's not potassium sparing, so they're probably going to need some type of potassium. So how do you choose B or C? What factors do you think of in deciding whether to teach them to do B or tell them C?
Hyperkalemia, so B.
Right, so they're going to have excess potassium, yes. So the question is, do we teach them that they should eat foods rich in potassium, like bananas and orange juice, or do we tell them that, oh, the doctor's gonna give you a potassium supplement along with this medication?
I think it's C, because we can teach the patient, but what about if he doesn't eat a high potassium diet? He's gonna be a risk for hypokalemia. So
correct. However, yes, you're right. I would look at some of the things in the chat, because they're saying what you wanna do is the least restrictive, the less medication as possible. So we want to give him the opportunity to eat bananas and drink orange juice, right? Non-pharmacological first, right? So we want to teach him that first. Then if he comes back and we do his labs and his potassium is really low, right? Then we can go from there. We can ask for a nutrition, right? Nutrition as a concept from last week, right? We can ask for a 24-hour diet recall. Well, tell me what foods you've been eating. What if he tells you he doesn't like bananas? What if we didn't ask that question, right? So now we should find we need to ask about other types of foods with potassium, because me personally, I'd be drinking gallons of orange juice. I hate bananas. So, right? So in our assessment, we would figure that out. Does that make sense? Least restrictive, and that tied into nutrition. Look at that. Yes. Okay, so those were some practice questions. Same things you have to know. And I said PTT. I'm not going to put a test question on there, but know that in case you get asked about. Know that there's tests that check for clotting times and effectiveness of heparin and warfarin. Right, so that's the same things. Yes. Okay. Click to exit. So does that? Do you feel like you have a little bit better understanding of hypertension and perfusion and hypertension?
Yeah.
Yes.
Yeah, yes, okay. Then my goal is met. Oh yes, with a smiley face, thank you. Okay, so then what I would like to do, we did that. Let me show you I put I don't know if it's a study guide, what you want to call it. I just threw it together while watching Hallmark movies all day yesterday, because that's what I do on the weekend. And so it's kind of long, but bear with me. It may help you, it may not. It's here if you need it. So this tells you how blood pressure would regulate, like how you get to homeostasis, right? So if you have increased blood pressure, right, these are the things that are going to happen, and it's what your body normally would do, right? This is how blood pressure regulates itself. Usually the first line therapy is diuretics or, ACE inhibitors. And then this is sort of a list so that you have it sort of in the order that it would go. It'd be like the diuretics, and then maybe you'd throw in some calcium channel blockers, right? It just gives you sort of that little flow there. When you're thinking of blood pressure, short-term regulation, right, is the vasoconstriction, vasodilation, right? That's the initial. Murder, She Wrote, yes, of course. Magnum PI is the other one. Right, so hopefully the receptors, your body is able to, through the release of calcium, that type of thing, regulate vasoconstriction, vasodilation. For long-term regulation of blood pressure, you're looking at the renin-angiotensin or the renin-angiotensin-aldosterone system, the RAAS. I was talking with Ms. Clark last night. I call them the rodents of unusual size. Anybody know Princess Bride? Yeah, right, RAS. So this helps you, if you're looking at this diagram, if I tell you that they're getting an ACE inhibitor or they need an ACE inhibitor, see right here? That ACE, it converts angiotensin 1 to angiotensin 2. So if I use an ACE inhibitor, I don't get all of these high blood pressure things. It keeps the blood pressure down. And so basically what I did then is go through each of like ACE inhibitors. This is not the be all end all, please don't take it that way, but it's just a couple, medications, talks about it. When you're looking at beta blockers, right, it has to do with this beta 1, where are these receptors, right? So the beta 1s are in the heart. The beta 2s are in the blood vessels. And so you have cardiac specific and non-specific beta blockers. I don't know if you guys know this. I don't want to is this okay? Or you know this already?
I know nothing. Please continue.
Please continue. Okay.
I wonder,
So, yes.
alpha 1 in the vessels?
I'm sorry, what?
Is it alpha 1 vessels? You said
Yeah, there are 2. I did, but I'm talking about these. I'm talking about beta blockers. There are also alpha blockers, yes, but I'm specifically talking about the beta blockers right now. And I know class is done. If you want to go, I'll keep talking so that you have it. But you're welcome to leave, or if you have questions, put them in the chat. So non-selective, so they can reach beta 1 and beta 2, or selective, like they select specific ones. So again, you're gonna have, I think, metoprolol, I think you have, and maybe atenolol. I forget which ones Mr. Beamer put on your list, but it tells you like which ones are used for hypertension, whether they're non-selective or selective. So you kind of have that. I only put side effects for beta blockers because they're contraindicated for patients with a bradycardia or AV block, and in a patient with asthma or COPD, and to use cautiously in diabetics. So I don't know, I have no idea what questions she's gonna ask you, but beta blockers you need to be very cautious about beta blockers in people with these conditions. Okay, and then, oh, there you go. You have 1 heart, so beta 1 is, oh, nice, I like that. And you have 2 lungs, so beta 2 is lungs, which is why yeah, exactly. Nice. Calcium channel blockers, again, just sort of a list. We talked about in one of the slides about, or up above, about calcium crossing, and that's why you have a calcium channel blocker, to keep the blood pressure down, because the calcium keeps the vasculature, with the calcium moving, it keeps the pressure stable, or increases it. And if we don't want it to increase, we're gonna block it. I think I want to say amlodipine, I think, is your exemplar. But know that nifedipine is used a lot, and then sometimes diltiazem and verapamil, you might see those, but they're for more specific type things. Your ARBs, the angiotensin receptor blockers, go back to that diagram of the RAAS, right? And it will show you where that actually is working. And so these are the ARTANs, losartan, that you'll see. Don't really care about centrally acting alphas, but I put them there for you because you might see clonidine. And we actually in the spring had somebody on guanfacine, which I had never heard of before. And then here's your diuretics, and it shows you the different mechanisms. So like here it shows you this is where a loop diuretic works. This is where your thiazides work. This is your potassium sparing work here, right? So they work at different places in the neuron, in the kidney. You know, there's your glomerulus and the nephron and all that. So they work in different places. Thiazides are the ones that are most commonly used. And they have less, they don't work necessarily as well as some other ones, but they have less side effects. And then the loop ones are pretty good because there's a huge impact there. So that's, and then another little table there. And then if you want more information, the CV pharmacology, that one was pretty good. That's where I got most of this information. Your ATI is fine. I mean, all the resources you have are fine. I just kind of was looking for sort of a couple page quick thing if it would help you understand where you have to understand what regulates blood pressure to understand why certain medications work certain places. Does that make sense? So that's what I was trying to accomplish for you. Oh, good. I didn't even know there was a discussion. Yay. And Kathy Parks. Yes. Whitney says she's been looking at Kathy Parks. If you like Kathy Parks, if you like the Purple Nurse, whatever works for you. So hopefully that helps. Okay. And then what I will do, because you have some resources there, what I will do, I gave you, where did I put it? Oh, did I not? No. There it is. I gave you this document. I don't know if it will help you. I can put like a little video together if you want for that, because I don't want to take up more of your time than I have to. But I still have 36 people. So if you want me to, I can. I'll just talk to myself. If people need to leave, that's fine. Do it. Okay. Hold on. Let me. I'm trying to help here. I'm trying to take feedback that we've gotten and see if I can get you guys pointed in the right direction. Yeah, 150 over 90 is kind of high. Huh, okay. So you guys have been working with the concept map that you have in your clinical worksheet, right? And so what that's based on pretty much is your assessment, you know, the information that you sort of are all putting together, and then what problem you need to look at. This is another way that I found that helps me, but again, it's up to you. So for example, I don't know, can we do annotations on this one? Probably. Hugo, can I annotate on this?
That's actually in Word. If you, you should be able to.
I should just be able to type on it, huh?
You should just be able, you can either just type on it, or when you're in full screen mode, if you go to the window where it has like chat and participants and all that, you'll be able to click on there and go to annotate and just annotate.
Oh yeah, I have annotate. Okay, I can do that. So if we look at, so this is basically, these are the concepts that we're looking at, and they're actually sort of in the order that we're looking at them. So nutrition, perfusion, gas exchange, blah, you know, going all the way around. And so what might be helpful is you're looking at your client information. So what did we have? We had, that's awfully large. Oh, well, what did we have? We had a 58-year-old African-American male, right? So that's, right? And so you can put your client information there, more information is fine. I just remember 58-year-old African-American male, right? We don't really know what medications I think that he was on, but you can put, you know, whatever, what do you want to put him on? What medication do you want to put him on? Anybody?
Can you say that again? Sorry.
Medication. What medication do you want him to be on?
Metoprolol 20.
Metoprolol, okay. We'll just put metoprolol. I'm just giving you examples. What concept map is that? Amlodipine is, I'll have to look at that concept map. And then you're going to do your assessment, right? So what information might you put under nutrition? Anybody have a hypertensive patient in clinical?
I am a hypertensive patient.
Yes, you are a hypertensive patient. And among other things, but what do you eat? Not like what should you eat, but like what is your current diet?
It is
one up.
it's low protein, or I'm sorry, low protein, low sodium is what it is. What it comes
So
out
you
to.
do a low, so low sodium. And then perfusion, we're gonna look at your vital signs, for example. So let's say your heart rate is, I don't know, 88, you know, O2, no, cap refill, less than 2 seconds, what, you know, whatever goes there, right? That's your perfusion stuff. Give me a blood pressure.
Mine this morning was 131/78.
131, you must have a monitor.
Yes.
Because you can't get 131 on a manual, just saying. And then you'd want to say what, left arm sitting or what, you know, whatever. I'm just going to make that up, right? Because you always want to know which arm, sitting, standing, right? And so you're going to do this throughout the whole, you know, if there's things that you may not have talked about sexuality, that may have nothing to do with it. That's fine. What was your fasting glucose this morning? If you did
Fasting glucose this morning was 118.
118. Okay, so you're under 120, so good. Right, and so this is where all your assessment data is going to go. Does that make sense? And so then I'm going to look at it. Oops, where did I go? Oh, hold on. It won't let me move if I'm there. Okay. And then you're going to go and look. Oh, sorry. I forget that it does that. My bad. Oh, dear. All right. Hold on. Let me erase all that. Right. But does that make sense? That's what you're going to, right. You're going to put all your assessment data in all those different categories. Make sense? Yes, no, maybe. Sure. Okay. Some nodding heads. Thank you. And then you have that basic, like why they were admitted, how old they are, allergies maybe, and just list the medications. You don't need to necessarily know the milligrams or how often. You should be able to tell a lot about a patient just from the medications, right, that they're taking. Okay. Yes. Yes. Okay. And so then what you're going to do is, right, you wrote down your objective and subjective, right? What did you specifically see? What did your client tell you? And then what you're going to do is you're going to draw arrows. Like, how are things related? So like nutrition, say, you know, he's eating all this salty popcorn, like nutrition affects perfusion. So I can draw an arrow between those concepts. We're looking at the interrelated, sorry. Oh, I do have arrows. Look at that. That might work, right? So like, right, nutrition goes to perfusion, and then perfusion actually goes across to hormonal, right? It could go back and forth. Maybe they tell you they're constipated, so, you know, nutrition might have to do with that. It could also be medications, right? It could be, but we're looking at hypertension as our exemplar right now. They just started nursing school, right? So stress and coping is gonna, like, that's probably gonna go both ways, right? But do you see how you're making relationships between these concepts? And so then if you're looking at, I have to take it out of annotate, and then I have to erase everything, or it won't let me go to the next page. Sorry.
There's a clear button. If you click on clear, it just clears everything
Is
for
it?
you.
Oh, I see that now. Look at you. See, clear all drawings. There we go. Oh, I like that. Okay. So we know that we had relationships, and they're kind of either going back to nutrition or perfusion, depending on what your assessment for your patient is, right? So we drew arrows to see what relationships are. And are there concepts with a lot of arrows, right? Like perfusion or nutrition? Or is there maybe something that doesn't have anything pointing to it, but that has sort of become a concern or you've noticed? Because that might be something you want to address as well. And so the top two or three concepts are important for your patient. What would you say for our hypertensive patient they were? Say for our nursing student, what do you think are the concepts that stuck out?
Nutrition.
So nutrition is one. And what's another one? Oh, stress and coping. Sorry, I'm not reading my chat. Right, stress and coping.
Physical activity, mobility, maybe.
Yeah, we didn't really talk about it, but it could be if that's what you. I'm trying to go back to perfusion, right? Because they have hypertension. However, having said that, maybe they're not exercising, right? Maybe they tell you that they have limited mobility or they're edematous or something, so it's really difficult for them to exercise. Okay, so those are like our 2 or 3 things that we're thinking. If I had 5 minutes with my patient and I could teach them anything that's going to help them with this concept that they're dealing with, what would it be? Right? Bang for your buck. So I've identified, I've assessed, and now I'm doing my analysis now. I'm looking at what my potential teaching points, potential hot spots are. And it could be medications, it could be, knowledge deficit type things as well. And so then you go, I hope this is making sense. Soft tissue problems, stress and coping, there you go. So then what you do is you've done that, you've narrowed it down now to those couple things, and that's part of your analysis. So you could say, whatever the client problem is that you want it to be, maybe it's decreased mobility related to swelling of tissues, as evidenced by patient states he can't exercise or doesn't feel like he can exercise or something, or the nutrition, alteration nutrition, increased sodium in the diet or decreased intake, fluid intake or something, right, related to whatever it is, as evidenced by the patient eats whatever salty foods, right? You can list salty foods or states or patient states they don't know. I'm more interested in like what the client problem is and what it's potentially related to, because as evidenced by is your assessment. It's what you already did, right? That's how you know that there's a problem, right? So that's your analysis. And this should look like your clinical worksheet, only a little bit different. Because now if you take your plan is your short-term goal for that shift. So if the issue is mobility, what is a short-term goal that we could set for our patient? Right, they have hypertension, they're in the hospital for whatever, and mobility is an issue. We want them to exercise a little bit more, but they've kind of been on bed rest, but they can get up, they just haven't been. So what might a short-term goal for our patient be? Range of motion. Ooh, those are good. Okay, so is that passive or active range of motion? Get up. Get up is good. However, I kind of like walk around the room 3 times before the shift is done. Or range of motion Q2, SMART goals, yes. So let's do this. Let's do range of motion, Q2, and then for our second short-term goal, we can do some type of ambulation thing. So, excuse me, how would you write that? Patient will perform, we'll do what, lower extremity? We'll do lower extremity range of motion every 2 hours. And how many like reps or how much do you want him to do? Because as the nurse coming on, if I read that, I'm not sure. I know he has to do range of motion. I can remind him, but I'm not quite sure what exactly he's supposed to be doing. Do you want like 10 leg lifts each leg? Something like that? Or knee bends, or we'll do 10 leg lifts each leg. Something like that. Oops. Sorry. Right, so every 2 hours, 10 leg lifts each leg by end of shift, right? Actually Q2 hours, but everything's by end of shift. Does that make sense? Is that specific? 10 leg lifts each leg. Is it measurable? I can measure that. A time frame. It's attainable. He should be able to do it. Measurable time, and I have a time. So I think that's good. Does that make sense? So I have my goal, and then my implementation. That's my plan. It's my plan. I'm planning. This is what he needs to do. How am I, as the nurse, going to get the patient to that goal? What are the nursing interventions that I'm going to do to help the patient get there? Okay, I'll just, it's okay. So I can assess, a lot of times assess is the first thing. Does assess if he knows how to do range of motion, or how about we'll do knowledge of ROM, right? And then I'm going to teach him how to do the range of motion, right? And then the teaching point would be why he needs to do the range, why he needs to do the range of motion, like what it's going to do for him, right? And then what's my evaluation? How will we know that the client met the goal? Right? Oops. Done intervention Q2 hours, right? That's literally what it is. That's how we know that they met the goal, because they did what the plan was. What if they were only, so say it's at the beginning of the shift, it's an 8-hour shift, so that's 4 times they should do it. So what if they only did it 2 times instead of the 4 times that you wanted them to do it? So he will have done the range of motion. So now what if he hasn't done it, right? Then you go back and you figure out why. You assess why didn't that happen, and then work with them. Maybe he forgot, right? So then you say, well, would you like reminders? Or here, let's set your clock or your phone, or, you know, I can try to remind you, or, you know, things like that. Does that make sense? And I got there, he participated, said he was in pain or dizzy. Yeah, asked, yes, very good. Assess if there was pain. Ask what's the best time for them. Yep. So pre-medicate, that kind of thing. Nice. And ask what's the best time, right? So I got there from this type of concept map. This is a little different, but it's different, but it's the same in that you're doing the assessment and then analyzing, you know, what the problems are, and then you have your plan and your interventions and your evaluation. This just has to do with like teaching, but I wanted to focus on the care. So this is your plan of care, right? This is what you're planning to do with your patient, and this is how you know whether they reached it or not, they reached their goal or not. So if this concept map works better for you, you can do something similar to this. You can do the clinical worksheet. You kind of have to put that information on the front page of the clinical worksheet. But if you want to transfer that to a concept map, if that helps you, that's good too. So we just didn't want to initially confuse you with the other concepts, the interrelated concepts. But I personally, I mean, I came up with this one. I've been using it for quite a few years. But I think it kind of helps you see how things are related. Because if you have everything going towards mobility or everything going towards perfusion, then that tells you where you need to be looking. And we're not necessarily looking at prioritization in first semester, but that's eventually where we're going to go. So of those, 3 goals or interventions, which one is the one they need to do first, right? That's where you will eventually get to be able to prioritize. So take that, modify it. That's just how my brain works. Hopefully that was helpful. Let me stop sharing. And I know we're over. Thank you guys for staying. I appreciate that. I did, it is recording. What other questions, or is there something about the concept map or the thought process that you have that I can answer or try to answer? Sounds good. So Friday we have, we're doing evidence-based practice and something else in 47 that I can't remember off the top of my head, but it'll be me on Friday. I know there's an exam on Monday. You have the question distribution, which tells you how many questions, right, per topic, per concept, right? So you know where that kind of is. Go back through the objectives and do your study guide from the objectives, right? That's where we're going to draw our questions from. I try in my PowerPoints, it's the that's a wrap slides, like that's what tells you what you need to go back and kind of focus on. And yes, it is posted, and it is, I believe it is in the syllabus module. Let me, yeah, it should be, whoa, that one. Question distribution. Maybe not. Where'd it go? Should have taken me to a page. Did it not take me to a page? Maybe not. Oh. Gads. There we go. Where did it go? So this will tell you like where the focus will be. So like there's only one question on S-bar. There'll be like 4 on therapeutic communication. There's only 30, not only, I shouldn't say it that way. There's 35 questions at 70 points. And it tells you it could be multiple choice, fill in the blank, like what the point spreads would be for that, but there'll be that many questions and a lot on perfusion hypertension. And then I can point you in the right direction for the evidence-based practice. I was going to do that one asynchronously because Fridays, everybody's really, really tired. But if you want to do synchronous and record, I'm happy to do that as well. But know that you guys obviously don't have to attend, but I know we crave the contact. And what we'll do if we're looking up articles is we will actually look up articles related to either hypertension, iron deficiency, anemia, healthy eating, those kind of things. We'll go back and look up evidence-based practice. The activities that we give you or the homework that we give you, which there isn't any for evidence-based practice or perfusion, by the way, are to help you solidify the concepts. So hopefully, because I know some of the comments in the quiz were that you're spending all your time doing that instead of studying, except that is supposed to be part of your study. I mean, that's how we're looking at it, is if you're looking up information or doing certain things, then that should be helping you grasp the concept a little bit better, hopefully. And then again, here's exam 2. It'll be 45 questions, 90 points, gives you the number of questions. And then for the final exam, we have it broken down or broken up into what wouldn't have been covered on an exam yet. So that's those questions. And then the cumulative content from the other weeks, 60 questions, 120 points. And it gives you the breakdown there. So hopefully that helps. If you go back to the objectives that are listed and look at your, look at the question distribution, hopefully that will help. Okay. Stop sharing. What else? Anything else? If I do asynchronous, I have no idea. Probably it would be posted by class time. So what do we do? 8 o'clock on Friday? Usually 8 o'clock. Who does anything at 8 o'clock? 8 o'clock. 8 o'clock. I'd have it posted by class time. But it's just you guys are generally so tired on Fridays. Like, you know, we're trying to be mindful of that. And if you wanted to, you know, have that time to study or something, I'm pretty sure I can do 47 asynchronous. So that would be posted by, what is that, 10 o'clock? So that'd be posted by 10. Alrighty, let me know if you guys have questions. You know how to get a hold of me. Thank you for staying. I appreciate it. I hope that stuff helped you. And yeah, so I will stop the recording. Stop your